Numiso Chuma from Best Health Solutions. I'm Dr. Numiso Chuma from Best Health Solutions. And today, we are going to be touching a subject that is of interest. A subject that is of interest to myself and the rest of the Best Health Solutions team members. Something that we're really passionate about. Something that we're always looking forward to do in the communities that we serve. Something that we live for as a Best Health Solution team members. There are certain things that we're really passionate about, that we push on a day-to-day basis, that we make it a point that when we get up every morning, we're looking forward to it, and that is community-led research. Community-led research, and it's one of those things that says, in every work that you do, you'd find that there are certain things that actually drive you, that actually brings in that energy in you, and that zeal in you. When you are doing things that you are really passionate about them, you would find that you're likely to grow within your organization. You're likely to get more and more people, appreciating the work that you are doing. So on a day-to-day basis, I'm so passionate about community-led research. I'm so passionate about getting to undertake research initiatives, getting to be part of the broader research community, getting to be part of contributing to science, but from a community perspective. It's one of those things that I always say that I was born to do research in the communities, because I really enjoy doing research, because the research that we do, it drives change within our communities. It brings about changes, that long-lasting changes within our communities. It brings about transformation within our communities. So hence today I'm going to be talking about community-led research that you can also be part of, that you can also actively participate in, be it in your little corner somewhere, as part of the community, or in some cases, some of you could be pursuing further studies or undertaking research initiatives, or some of you could be part of the community-based organization space, where you would want to do some research initiatives or some work that drives change within your communities. If you're passionate about something and you would want to drive change within your communities, one of the key things that you need to be passionate about, it should definitely be undertaking research initiatives. And that's one thing that I want to talk to today. So community-led research, basically this is an initiative that is largely targeted at empowering the local communities or local populations. And the idea behind it is to actually drive change within our communities. It to actually translate to a situation where on a day-to-day basis, from the work that we do, it becomes tailored to the respective communities that you are working in. Because you find that in the communities that we serve, there are lots of community initiatives that get to be undertaken. There are lots of programs that get to be designed or developed. But based on those particular programs that get to be designed or developed, they are not always tailored to the communities that we serve. So it is key and critical that as community-based organizations, we take a leading role in ensuring that the programs that we do at a community, in our locality, they actually actively involve community-based organizations. That community-based organizations, they are an active participant, or key population groups, or the communities that we serve, they're an active participant in the day-to-day operations, into day-to-day implementation of our programs. And one of the key things that these community-based organizations or these community people need to play on a day-to-day basis when it comes to program implementation is that they get to be not only be part of the implementation, or to be part of the people that get to be mobilized. Because you find that as community-based organizations, one of the key things that we want to achieve are the numbers of people that are reached. Now, so it's not just about number of people that get to be reached. We are looking at how best can we come up with integrated health services. How best can we get community organizations or community people to be indeed part of the community activities that we are planning to do. So you find, let's say there is a grand initiative that we are presently having to say we would want to ensure that we reach out to as many community people as possible. We undertake research, we undertake community initiatives that maybe to increase PrEP uptake, to increase HIV counseling and testing, want to increase maybe different modalities like condom distribution, want to increase numbers of people that are retained in care, want to increase numbers of partners that accompany their partners to health facilities. So all of those could be initiatives that we want to do within our communities. But we need not to come with those initiatives without consulting the communities that we serve. What we need to do is that we come up with initiatives, we craft those particular initiatives and those particular changes that we want to do within our communities. And then when we've crafted those particular, be it at a high level, or it's at a provincial level, or at a national level, or it's a national level program that needs to be undertaken, when we've come up with that particular initiative, we go to the respective communities, we engage with them, we get to talk to them about, what do you think about this particular initiative? How best do we improve service provision at a grassroots level? How best do we drive change in the localities? How best do we come about improvement? Or how best do we, say, increase PrEP uptake? Because you find that from time to time, we always come up with interventions. From time to time, we always come up with programs. And some of these programs, they end up not becoming successful. And largely, it's because some of these initiatives that we come up with, we're like parachuting them into the communities. We're like bringing them into the communities without consulting the communities, without getting communities to be active participants in terms of crafting, molding of the initiative that we are planning to do. So it is key and critical that as community-based organizations, when we come up with community-level initiatives, as civil society sectors, when we come up with community initiatives, when we want to increase, let's say, testing of community people, when we want to increase, let's say, retention in care of community people, when we want to increase engagement with the communities, when we want to increase sensitization of communities about access to health services, we get to make sure that they are active participants in that particular initiative. So community-led research is one that brings in those elements. It's actually a manner through which we empower local communities or local key population groups to actively participate in the research process and ensuring that studies are relevant and beneficial to their specific needs. And some of these key things can easily be achieved. Oh yeah, Patience Langer, I see you have already posted a question there. How does the organization ensure they truly represent the voices of the communities? Perfect. A very good questions. And one of the key things that as community-based organizations we need to do is that we make it a point that, like you are putting it, that we are truly representing the voice of the communities. And those are some of the things that we're going to be talking to actually today, and how we can potentially do that within our question. Very, very key and the critical question. And just to answer that question straight away is to say that the starting point when it comes to the work that we are doing in the communities is to ensure that there is active participation of those particular community members. And one of the key things that we always do as civil society organizations is that we reach out to the communities within the districts that we're serving or within the catchment area of our community-based organizations. What we do is that we reach out to the different sectors that are serving within our communities. We reach out, let's say I would want to do a program that is targeted at men, and I'm part of the research sector. If I'm targeted at men, I'm going to reach out to people within the men's sector. And so that I can go to that particular community, to the community that I'm working within, and then we engage with those particular men. If, let's say, I want to go in and target the LGBTQI community, I'm going to go in and say, okay, these are the people that I want to target, and then I'll come up with interventions or strategies through which jointly come up with intervention, or jointly come up with tools or data collection tools that will be used jointly between myself, who's in the research sector, and those that are in the LGBTQI sector, to go into the community. For example, the faith-based sector is coming up with a study, let's say it's targeted at youth. They want to increase uptake of services amongst youth, or they want to increase sensitization of youth within the communities. What they will do is that they will then, the faith-based sector will then reach to the youth sector so as to increase those kinds of engagement between themselves as the researchers and the respective communities that they'll be working with. So that is a key and a critical step when it comes to the actual design of the programs, when it comes to the actual crafting of the programs, to say that you don't bring in the targeted communities, you don't bring in the key people from the communities at a stage where you've already crafted your study, at a stage where you have already collected the data. They need to be involved from the conceptualization of your study. That is why you find that as civil society organizations, one of the key things that we do is that we get other civil society leaders to actually participate in the crafting of the study. For example, the most recent work that we are doing, we got the different civil society sectors to actually craft, to actually come up with the different topics, to actually come up with the different initiatives that could be undertaken in their communities. When they've come up with those particular topics, we know 100% sure, because they belong to that particular, say, key population group or to that particular sector, they've got an in-depth understanding in terms of the challenges that they're facing in those particular communities. And then when they've crafted those, we then sharpen those particular ideas jointly with them. So we then develop the data collection tools jointly with those particular groupings or with those particular sectors. So that way, we ensure that the work that gets to be done is actually tailored to the communities that we are serving. We ensure that the work that gets to be done is relevant to those particular community groupings, that will be working with. So that is one thing that is very key and critical, particularly at the initial stages where we're doing conceptualization of our work. We make it a point that we actively involve the key population groups, we actively involve the targeted communities when it comes to the work that we do. So that is the starting point. Actively involved in the design of the program, actively involved in the actual implementation of the program. This involves getting them involved in the process of data collection. So you find that if you want to go and collect data amongst youth, you must be a youth. Now, it is true that some of us, we want to undertake our studies for research, for academic purposes and all that. But if you are coming up with a program that is tailored for a community and you want to target adolescent girls, you must be an adolescent girl. Now, the best way to go around it, if you are not an adolescent girl, you're an adult and you want to reach out to adolescent girl, you could capacitate some adolescent girls to assist you in that particular process. You groom them in the direction of saying, train them how you collect the data, how they analyze the data, how to engage, how to facilitate the dialogues. You train them on those particular aspects. Then when you've done the training, and then you allow them to go and collect the data. Of course, there are people that are skilled in terms of how to engage with young people and all that. But it is always good to get the youth to engage with youth. For example, it's good for a man to engage with men. It's good for women to engage with fellow women, so that, there isn't that part of like some of the barriers that might exist in the process. And there's that, in some cases, there are some cultural aspects that come to play, like how do you address the other person when you are from the other gender or the gender identity. So there's an aspect to do with, we make it a point that when we craft our programs to ensure active participation and to ensure that the different stakeholders, they get to be involved to be in a position to reach 1.1 million people, and so that we can cover the HIV treatment gap. What are some of the interventions that we need to come up with? So you begin to have consultations with the different key population groups that are within our communities. Can you hear me? Can you hear me? Can you hear me? Okay, perfect. Sounds good. All right. So there's a part that says, in the day-to-day work that we are doing, we need to make it a point that we engage the respective communities. We engage respective people who are within our communities. For example, if you are to talk about improving men's health, what we need to do is that we reach out to men within our communities, and then we get them to be active participants. So you find that some of these men could be found in churches or in places of worship. Some of these men could be found in bars, in nightclubs. They could be found in sports ground. They could be found in workplaces. They could be found at the gym. And it would be good for me if I'm going to this particular gym and then I go to that particular gym to go and interview men at the gym. If I'm going to this particular place of worship or to this particular, area of congregation of men, I go and interview men in that particular area of congregation. But if now I want to reach out to men, let's say in another place where I don't normally visit, it will be good for me to go and find out who among these men, who could I potentially partner with, or who has got some authority there, or who could be the gateway through which I get to that particular population group or to that particular team of men, so that we'll be in a position, to engage with them, to get to understand exactly, why is it that there is low uptake of health services among them, and then from there, when I engage with them, and we get to talk about the fact that these are the challenges. These are the challenges that we are currently facing as men, or these are some of the barriers that we see as men in our communities, or these are some of the things that are actually bringing about us, are actually making us not to be willing to go and visit the health facilities. And then from there we can say, but I hear you. You are saying that the main challenge is that maybe there are mostly women nurses in these particular health facilities. How best can we ensure that there is ease of? Is it because of the gender? What could be the what could be the main challenge that you could be facing in your community that is translating you not to be in a position to visit these particular health facilities? And then from there, they would then give an indication to say, no. Actually, maybe it's a problem with the fact that I feel uncomfortable, or it's because of waiting time in these particular health facilities. They'll be like, oh, okay, apart from, and being uncomfortable, I hear you that you're talking about the waiting time that is at these facilities that is making you feel like not going to these particular health facilities. And then from there, you'll be like, okay, so how can we do it differently so that you can increase access to these health facilities in the communities that you that in this particular closest health facility that is closer to you. And then from there we can then ask to say, we can then even give them options to say, what if we got you not to stand in the queue, but we made a prior arrangement because there is someone who's working in this facility, and we can link you up with the nurse or with someone who's working in the facility, so that when you get there, you can go straight to this particular individual, and then from there they can provide you support at the facility. So would that be comfortable with you? So at that particular moment, what you are trying to do is to get an understanding to say, I understand. Generally, people are saying men have got low health-seeking behavior. But as a man talking to another man, I'm saying, how can we increase your ability or the chances of you going to the facilities and accessing services? Because at the end of the day, we might want to test these men. But if we don't engage with them at a personal level, to get an in-depth understanding in terms of what exactly is making them not go to these facilities, there is no way that these men are going to go to these health facilities. No matter how many times we put out messaging to do with, you need to go to the facilities, these are the dangers of HIV, these are the dangers of TB, these are the dangers of, no matter how many times we come up with scare tactics, we call them sensitization initiatives, that are going to be going to these particular communities that we think that we are serving. There is no way that we are going to drive change within these particular communities. There is no way that there is going to be an increase in men that go to these health facilities. We need to come up with practical solutions that get to solve these problems that we're having in the communities. Because some of these problems, we already know them, but we know them theoretically, we know them generally. We are actually generalizing the nature of problems that we're having. Yet, there is a human element to these particular problems. We need to come up with solutions that are co-created and co-designed with men in mind and men in the center of the work that we want to do. So there is a lot of work that needs to go into crafting of what needs to be done so as to increase uptake of health services, much more than mass media, mass communication, mass information going into the communities. Because if that was the case, where if you go into a community, you tell them, they then go all to the facilities. Oh, we could have long sorted out all these problems. Which means the main issue will be information. But we have discovered that over the years, everyone knows about TB. Almost everyone knows about the health problems that are there. Almost everyone knows about GPV. Some of these people, they've even been arrested before, they've gone to prison, they've come out, but some of them, they are still violent, they are still doing GPV. So some of these people have gone through this particular process, but, they've been sensitized. Some of them, they even went to school. Some of them have got even qualifications in NCDs, but they are still not, some of them are even nutritionists, but they are not even eating healthy. So which means there is something that is missing in the broader scheme of things. And that thing, no matter how many resources we put into the communities that we are targeting, there is no way we will solve the problem. That problem cannot be sorted out by us pouring resources into the communities that we are serving. It can only be sorted out if we come together, we say, okay, how best we engage with these communities? How best do we come to a point where we drive change within these particular communities that we are serving? And the easiest way to do that is for us to be in a position to sit with these particular communities. We sit with these particular key population groups that we are talking to. For example, in this case of talking about men, we sit down with men. As men to men, we talk about it. As men to men, we engage about it. We begin to say that some of these men, they would listen to the guys that are from the faith-based sector. We then say, faith-based sector, please talk to men. Engage with men in your churches, in your places of worship. We then say that some of these men are likely to listen to children. So what we will do, we will come up with games. We will come up with creative ways of posing these particular questions. And then we would go to creches, to ECD centers. We'll get to say, at this ECD center, we are undertaking a study where we would want to ensure that there is effective engagement or there is effective discussion on issues that relate to why men are not visiting health facilities. And we come up with an initiative where we ask the young ones to say, why is it that fathers are not participating are not accompanying children to health facilities? Why is it that uncles are not accompanying, children to health? We're not directing it at their father, but what we are doing is that we are talking generally. To say, they've been asking to say, there's this story about John who is married to Zippo. And John got Zippo pregnant. And then when she was pregnant, she was going to the health facility alone and coming back, tired, but still she had to cook. But John was also coming back from work and would not cook at home. And then from there, we then pose the question, right? It's now an assignment that these kids want to go and ask at home. Why is it that John is not accompanying Zippo or so and so to the health facility? Or so and so is discover that they've got TB, and then they go to the health facility, and then when they come back home, they still need to cook. Then they are told that they need to come with their partner, but their partner is not willing to come. And we ask a question to say, but why is it that their partner is not willing to go to the health facility? What could be done differently? So then we are asking these young people to say, come up with these kinds of things. This is an assignment that you need to go and study at home. So it begins to bring in, of course, we'll make it age specific and we'll be sensitive to those kinds of cultural sensitivity even when we're crafting those kinds of work, we craft it in such a manner that it is culturally and socially acceptable to that particular community. But the basic idea around it is that in as much as we are saying part of the work that we are doing, we want to target men because there is low uptake of services among men. There is no way we can come up with initiatives that don't engage men. But we need to engage men, not just talking, because so many dialogues have been done, so many discussions have been done, so many focus groups have been done, but all of that data is sitting somewhere and not being analyzed. And that is what is actually driving the problems that we're having. And it's even bringing in frustration, within our communities, because they have seen as much. It's not like they don't know about the service that we provide. The moment they see our van, that's the moment they get out of their homes and they go out. The moment you tell them about the health facilities, they know the health facilities, they've been to their health facilities. There is no way that they can say that they don't know about them. They know already. So, as civil society organizations, what do we need to do? We need to jump and say, what guys, we know the problems. And we know that we need to consult the relevant people. But not only consult them, we get to discuss with them to say exactly what is the problem. Before we even start launching some of these initiatives, pushing them down their throat, coming up with communication messaging. Because it's not an issue of awareness, but it's about tailored awareness campaigns. It's about co-creation of awareness campaigns, whereby we sit down with men. We get to segment them. We get to say, okay, these are the different kinds of men. This is how they think. We get to begin to talk about some of the touch points, some of the pain points that men go through in the process of moving from home to work and then to the health facility. We then say, at which point do they then decide not to go to the health facility? It is very key that as we are crafting our programs, as we are crafting our interventions, we come up with tailored interventions that are targeting our community. Because if we just craft our programs like we're doing business as usual, there is no way that we're going to reach out to these men. There is no way that these men will come out and say, now we're ready. We're just going to go and pick up treatment. We're just going to go and be retained in care. We're just going to, be adherent to TB treatment. We're just going to lose weight. We're just going to, because we know them already. And even when it comes to children, children are under the guardian of their parents or the guardians. And there is no way that these children will start being available or being seen in the community, which means there is a need for a targeted messaging that needs to go to mothers, to fathers, to heads of households, to grandmothers. All of those people, we need to have a targeted messaging. And that targeted messaging needs to be done by communities, with communities. It needs to be a co-created targeted message. Because if we don't co-create the message, we just do business as usual, whereby we sit as academics, we sit as, healthcare workers, we sit and then we say that we're gonna come up with a generic message, and that message will be of no value, and that is not going to drive innovation. We could be having lots of great initiatives, be it we want to get people to lose weight, be it we want to get people to be adherent to treatment, or we want people to be linked to care, or to be retained in care, or whatever interventions that we are coming up with. Messaging, it has gone out. There is a lot of messaging that is out there. There is a lot of community sensitization that is out there. And there is no way that at this particular stage we can say that people are not sensitized in the communities. People are sensitized. And it's not only the people that are in the communities, not only the men that we are talking about. We are also talking about the healthcare workers. It does not mean that healthcare workers, they don't know that they need to provide quality services. They know. They've been sensitized. They've been taken through lots of workshops around the fact that they need to be taken through, that they need to provide quality services. It's not like they don't know. Some of them have been shouted at, some of them have been put in suggestion box, some of them their names have been listed over and over again, some of them have gone even to Hello Peter. They are even known in the community, say that one does not provide quality service, that one is rude, that one is, but we need to go to the depth of the matter to say that how do we drive a situation where health facilities, they are in a position to receive these people and the quality of service is to improve. And these aspects are not quantitative aspects. Are not aspects whereby we need to get there and say, it's 20 people are saying this, 50 people are saying this. There's a relationship, there's a correlation between this and this one and this one. These are qualitative aspects. These are aspects that where we need to engage with the people in the communities, where we need to talk to health facility staff, where we need to talk about practical things that are happening on a day-to-day basis on the ground and say, guys, these are the challenges that we're facing, this is the direction that we're taking, this is the programming that we would want to do for the coming 6 months, for the coming 2 years, for the coming 3 years. But we want to drive practical change within our community. And if you want to drive practical change within your communities, what do? You engage with those communities. You get to talk with the different sectors, and then let's integrate research initiatives into our community work. Let's integrate research initiatives, practical research initiatives, whereby we are getting there with a children's eye. We are getting there with a children's mind. Because a child, when they come to you, they ask you a question. The next question will be, but why? But why? But why? But how come? But why? They've got an inquisitive mind. So as civil society organizations, as community-based organizations, as we design our programs, as people within the communities, as students within the communities, as we design our programs, we must have that mindset of saying, but why are things happening in this particular fashion? Particularly if the design of our programs is targeted at driving change within our communities. If the design of our programs is targeted at driving change within our communities, it might be tailored, it must be very specific, it must come with interventions that touch on everyone's pain point. It must address practical issues that community people are facing with. And it must segment people to say, there are certain people that have got a mindset like this one, and this is how they think, and this is how best we can do in the reach out to them. For these kinds of people, this is how best we can reach out to them. There is no way that we can say that everyone is through the radio because they are in the community, so it's a community radio station. Not everyone reads the radio. There is no way we can say that billboard, everyone. Billboard. If it was an issue of knowledge, we could have long sorted out this problem. Because we just educate them and make sure that in matric there is this. There's already life orientation, but there is something that is missing, which I want to talk to, which is called the intention-action gap. So there are certain intentions that we are having because of the knowledge that we are having, but the actual action that happens is totally different. So we could be having good intentions about what we want to do, but when it comes to the actual action, we end up doing something that is totally different and is not even aligned to what we were initially planning to do. And those are some of the key things that we need to be thinking about to say, how do we bridge this intention-action gap? And key is to aim to the point that we actively involve civil society organizations. We integrate research initiatives, implementation science initiatives in the work that we do. So it's not so much about doing business as usual, particularly if we are targeting driving change within the communities. Business as usual, it will yield the same results. You would end up finding yourself to say, no, the fact that there is low positivity is because, the numbers of people that are positive are very low, and the reason why the numbers of people that are very low is because our prevention programs are doing very well, our PrEP program is doing very well, we've been rolling out for a long period of time. But the actual reason is because the intention-action gap is still wide. The messaging that we're driving in the communities doesn't drive change or doesn't encourage the person to stand up and go to the facility. In some instances, it's even a situation whereby the facility serves as a barrier. There's no ease of entry to these particular facilities. But it's definitely ideas that are outside any of these ideas that I've stated. It's much more bigger than that. It's much more broader than that. And we need not to think about it. We need to reach out to these particular respective communities. We need to reach out to men in these particular communities. We need to reach out to mothers in these communities. We begin to engage with them. Otherwise, we'll end up wasting lots of resources if we don't have targeted messaging. In some cases, what we do in the health space, we do hotspot mapping, or we look at areas of concentration. We do all these geospatial mapping initiatives. And in those geospatial mapping initiatives, we target areas with high positivity. And then we say this area is good high, this one is a little bit, this one is a little bit. Of course, it's a technical way of looking at it. But the truth of the matter is that these things are largely not quantitative in nature. The challenges that we are dealing with, they are primarily qualitative in nature. We are dealing with issues that are actually qualitative in nature, where we need to understand the dynamics, we need to understand the community, we need to understand the manner in which people behave, we need to understand human behavior, we need to understand, like I said, the intention-action gap. How do we bridge that particular gap? How do we ensure that the people that are in these particular communities, the men, the adolescent girls, the LGBTQI community, the sex workers, they get to hit, the message hits them, and they understand and they buy into that particular message and they move with that particular message. So those are the critical aspects that we need to talk to when we talk about community-led research. When we talk about community-led research must take center stage in the work that we do. Right now we're heading towards World TB Day. There are 6 sectors that are busy doing incredible work, where they are reaching out. For example, the faith-based sector is reaching out to youth via also the youth-based sector, where they are saying, let's engage with the youth in the communities. Because they see value in us addressing issues to do with access to TB services, even in churches, even in areas of congregation, areas of worship. They are saying that let's come together, let's engage with the youth, but they are getting youth to engage with fellow youth. So all of those things, they are a clear indication that at least they are heeding to the call. To say it's not so much about the numbers. It's a lot more to do with the nature of messaging, who are we targeting, how are we targeting them, and then from there we package messaging in such a manner that it is acceptable to the recipient of the message. Because we need to, after collecting that data, it's not so much about data collection, because we've been doing lots of community dialogues and all that. It's more about co-creation of the messaging.
whereby we jointly co-create the message to say, for men, or for this particular grouping of people, or for people that behave in this particular fashion, or for people that believe in this particular fashion, or for people that have got these emotional aspects get to be evoked when this messaging comes to them. This is how best to package this messaging so that it's culturally, socially, and emotionally acceptable to them. So that's how far we need to go when it comes to tailoring messaging. We need to make it a point that our messaging is much more targeted and tailored, not a generic statement. Fine, we can have generic statements to say the campaign is focused on this and this and this, but we need much more targeted messaging when it comes to health communication. Otherwise, we'll do this work now, we'll do it next year, we'll achieve the same results that we achieved even in the previous year. But if we package it differently, if we come up with different interventions, we are going to drive change at the community level. So one of the key things, two actually of the key things that I would want to talk to is to say that how do we build effective community partnerships? So it's one of these things that says, as we are implementing health programs, we need to build effective partnerships at a grassroots level. We need to build effective partnerships that will facilitate the process of us to be in a position to drive change at a grassroots level. And as civil society organizations, the good part about it is that we are already working with different stakeholders. And by design, the civil society space, we've been segmented in parallel civil society into 18 sectors, where we've got the LGBTQI sector, the women's sector, the children's sector, the men's sector, the NGO sector, the research sector. And all of these, they are targeting different groupings of people within the communities. So, and one of the key parts is that they are what we call district AIDS council, local AIDS council, provincial AIDS council, and in these AIDS councils, we are bringing in different stakeholders, where we've got Department of Health, Department of Social Development, Department of Education, some cases Department of Agriculture, and other departments within. And then we begin to engage about some of these challenges. So it is key that as sectors, when we do our research initiatives, we sensitize these different groupings of people. We sensitize other sectors within your district. You sensitize these, social development, health, education. Because we are presently undertaking this particular study. We are presently undertaking this particular initiative to find out, to say what are the challenges that are being faced in the communities, how best to improve service provision, how best to increase access to services among this particular population group, among men, among children. So we need to sensitize them from the conceptualization of the study. I am conscious of the fact that some of these studies, they get to be crafted for academic purposes. But let's not just do studies for academic purposes, particularly if you're in the civil society space. You know the challenges that are faced in the communities, and those challenges are practical challenges because you've got lived experiences. Get yourself involved in the district or in the local or in the provincial. Go and present your study. They might give you something like 5 minutes, 2 minutes, it's okay. At least you get to sensitize them. You know what? This is the study that I want to do. These are the objectives of the study, and this is the justification of the study. I want to do this study from this day to this day, and I'll be at this particular health facility, and I would like to get your support. You know what? I'm done with my presentation. If you have been given a short space of time, whether it's 5 minutes, I capitalize on that. So it is key that we present studies that we are doing in the communities that we are serving, so as to ensure that we get stakeholder buy-in. Because when we do community-led research, it's not so much about collecting data. It's not for just general knowledge, for filing or for graduation. It's a lot more to do with driving change within our communities. Documentation and dissemination of a best practice. It's a lot more to do with driving change from our broader community, getting to support the initiatives that are happening at a grassroots level. So when we do our studies, let's keep that at the back of the mind to say, we are doing these studies to ensure that at the end of all of this, we inform a certain practice that is happening in our local clinic. at our local clinic. So we want to drive that change at our locality. It might not be even at a district level or a province, but at this locality where I'm collecting this data from, I would want to drive change. And that is very key and critical when it comes to practical implementation of these programs. Hence the value of stakeholder engagement. So it's very key that we engage the stakeholders that are involved in programs. Department of Social Development, Department of Health, at a health facility level, the sister in charge, all those key people that are in those particular health facility. They say, I'm doing this study within your catchment area, and this is what I want to find out. And then this stakeholder engagement also involves engaging with the key groups that you want to target. For example, I'll give you an example to say, let's say you want to increase uptake of health services among fathers. And then you have women that are coming to the health facility, pregnant and lactating women that are coming to the health facility. What if you say, in our community, for this specific health, we are talking about a change in your locality. Don't worry about national changes. For this specific health facility, we are going to allow women or ladies that come with their partners. And if their partners are willing to be screened for TB, tested for this, we are going to allow those women to jump the queue. What do you think is going to happen? How acceptable is that? So we are talking about practical solutions that could be done at a community level. So they must at least come once to the health facility and be screened. If it's the father of the child, they come once to the health facility and be screened. So we then say that since now you are pregnant, bring in your partner. If you come with your partner, on the day when you come with your partner, we are going to make you jump the queue. The woman would make a plan to make sure that that man comes to the health facility. They might not be the real partner, but at least they will be having someone who accompanies them to that particular health facility. At the end of the day, in terms of men, we'll have ticked men visited the health facility. And then that way, we're in a position to attract some of those men to the health facility. And generally, so some of them would come with their partners because they will be scared if they come with another partner and then from there they come back home early. That partner that got them pregnant might end up. But we need to engage with the community to say, what do you think about this particular idea? What do you think? Will this increase men coming to the health facility? Do you think that this will drive change within our locality, within the communities? So those are some of the things that we need to think about. But we need not to think about them in these sessions where we are sitting in the boardrooms and all that. We need to go and engage with men. We need to go and engage with women and say, what do you think about this idea? What do you think are some of the changes that can happen as a result of this particular intervention? How can this be done differently? So that's some of the things that we should be talking about in the communities, to say practical solutions when it comes to our facility here. So that when we then come up with those kinds of changes, we test them at a facility. We then say, instead of you coming with your partner early in the morning, rather come at 2. And then at 2, we know that we're attending to these ones, and that are coming in with their partners, or rather come at 4. So between 4 and this time, this is what is going to be happening. So those are some of the key things that I would want us